Good afternoon, doctors. How are you doing around the world? Today, I thought about the Pleural Effusion guideline, which is very important as well. It comes up in the exam many times. So let's go and read about it. First of all, we start with symptoms and signs. Investigate for effusion if persistent pyrexia or unwell 48 hours after treatment started for pneumonia. So this is basically if the child has a pneumonia and he's diagnosed with the pneumonia, but he is not improving anymore, despite starting the treatment for him. So he still have high fever, high temperature, beyond 48 hours, and he's still not doing well. So you have to think about a pleural effusion. So effusion to be referred to respiratory pediatrician. So in this case, you have to refer him immediately to the respiratory pediatrician. So in the exam, you will be asked to give a differential diagnosis list for this case. So you can say, mention uncomplicated pneumonia, malignancy, heart failure, pancreatitis, and pulmonary embolism. All these are differential diagnosis for the pleural effusion. What investigation you will ask for in this situation? You can ask for full blood count, clotting screen, urea and electrolyte, LDH, protein, albumin, glucose, and CRP, blood culture, sputum culture if possible. If recurrent infection, investigate for immune deficiency. You will ask for, again, full blood count, immunoglobulins, IgG, A and M, functional antibodies, and HIV antibody as well. For sure, you will ask for a chest X-ray, BA or AB, no need for lateral X-ray. We have in here very important questions may be asked in the exam, the ultrasound scan indication in this case, and the CT scan indication in this case. So the ultrasound scan indications, you need to do it to confirm. It's a diagnostic tool in here to confirm the presence of effusion, to check the maximum depth independent position, to differentiate between simple and complicated effusions, whether you can see loculations, heterogeneous material on the ultrasound. All this is important. Localize the effusion at time of drain insertion, so you know where you are going when you insert the drain. Okay, so of course it's not you will not do that by yourself. It's a complete teamwork. If history, if there's a history or positive history, you will do a chest X-ray or ultrasound suggestive of malignancy. So from the history and chest X-ray and ultrasound scan, you are suspecting a malignancy. So this is the first indication for doing a CT scan chest after consultation with your respiratory consultant. So this is the first indication for CT scan for the chest if you are suspecting malignancy from history, chest X-ray, and ultrasound. If risk factors for coagulopathy or thrombocytopenia, check and correct before drain insertion. So this is your checklist before thinking of inserting any drain. You have to rule out any coagulopathy or coagulation disorders and thrombocytopenia. Pleural fluid analysis. What are you looking for in the pleural fluid analysis? This is a common exam question as well. For sure, I will look for a gram stain and bacterial culture. I will look for differential cell count. I will look for cytology. And I will send for acid-fast bacilli and TB, PCR, and culture. So all these questions being asked in the exams so far. If cause likely to be infective, so if the cause of pleural effusion, it's obvious for me, it's like very high index of suspicion it's infective, so that's not necessarily to obtain a sample for pleural fluid culture routinely before chest drain insertion. So if you are sure 90%, 100% it's infective, you don't need to do pleural fluid aspiration or obtain any pleural fluid sample before the insertion of the chest drain. If you are thinking of alternative cause of the pleural effusion, so again, try to avoid the chest drain. It's not your priority to do it immediately by obtaining diagnostic aspirate of pleural fluid for cytology. Okay. What's the immediate treatment in here, and what's your first step to do in here with a case with a pleural effusion and he is unwell, pyrexic, and he is deteriorating? So first of all, you will start your supportive management, which is ABC, airway, breathing, and circulation. You give him oxygen and fluid resuscitation as indicated. Don't forget the most important element in here, which is analgesia, painkillers, very, very crucial. And the examiner want to hear that from you. Antibiotic therapy, it's according whether you have a community-acquired pneumonia or hospital-acquired pneumonia or a TB. So if it was a community-acquired pneumonia, we'll start Comoziclav IV with clindamycin IV. If he is sensitive to a penicillin, you will give clindamycin IV only. The second option, if you got a hospital-acquired pneumonia, in this case, you will start piperacillin, tazobactam combination. Again, if there's a penicillin allergy, you will shift to clindamycin IV only. If you are suspecting a TB, pleural effusion, so you will not do anything by yourself. You'll discuss with the TB team, and it's very important to say that I mentioned that in the exam because they want to know that, to make sure that you are a safe doctor. You are not working by yourself. You are working among a team. Okay. When organism sensitivity is available, use a narrow spectrum antibiotic. Okay. Another very common exam questions, when are you going to refer to respiratory pediatrician? Immediately if you have got an improving case of pleural effusion or complicated pneumonia. For sure you will refer to respiratory pediatrician. Early active treatment, reduced length of illness. If you have got a small effusion, what does it mean? Small effusion, it means that okay, so if you got on ultrasound small effusions that's less than 2 centimeter in depth, which are not enlarging or not increasing in size or compromising the respiratory function and do not need to be drained, so in this case, you will not refer to respiratory pediatrician. Underlying cavitating disease may lead to a bronchopulmonary fistula, so you will refer this case as well. So again, when you are going to refer to respiratory pediatrician, of course, you will not refer small effusions, only large effusions more than 2 centimeters. If there's a cavitating disease and there's a high risk for developing pleural fistula, of course, you will refer. Okay, the chest drain insertion. So once you have decided with your team that this patient need a drain insertion immediately, you have to discuss with your team. Your team is consisting of respiratory pediatrician, the consultant pediatrician, the pediatric anesthetic team, and the PICU as well. So again, respiratory pediatrician, the consultant pediatrician, pediatric anesthetic team, and PICU. You will involve the cardiothoracic team plus minus interventional radiologist in this as well. Okay, so again, keep in mind before you go ahead and insert this tube, you have to put on long line during the general anesthesia, a long line during the general anesthesia, and as well, you have to ensure vascular access before starting the procedure, and you have to do a chest X-ray after drain insertion. In this paragraph, we have a chest drain management. We can have a look on that quickly. Chest drain management ensure a nursing staff trained in care of children with chest drains. So the person who is going to look after this drain after insertion, it's a very well trained nurse actually. She will look after this drain if there's any blockage, cleaning, displacement, this kind of stuff. Attach a chest drain to low level suction, 5 to 10 centimeter water via underwater seal. If altitude chest drainage system used, set wall suction to 160 millimeter mercury per 22 kilopascal and set dial on drainage system to 20. I don't think this detail is very important for us in the clinical exam. Keep underwater seal below level of chest at all times, so that's going to be not at the same level of the bed. If more than 10 ml per kg per hour has been drained, clamp chest drain for 1 hour to prevent re-expansion pulmonary edema. So this is important point. When the trained nurse observing how many the output and the input, the output of the pleural fluid coming out, drained out, if the rate was more than 10 ml per kg per hour, she will inform you, and you have to request clamping the chest drain for 1 hour. So why your aim is to prevent re-expansion pulmonary edema. Never clamp a bubbling chest drain. If you have not seen any bubble in the chest drain, never clamp it. This indicates presence of a pneumothorax, and you need this bubbles to come out. If clamped and chest pain or breathlessness, unclamp immediately. So if you have decided to clamp the chest drain and you found there difficulty in breathing with the patient, and he is unwell, he's uncomfortable, so you have to unclamp it immediately. When there's a sudden cessation of fluid draining, the drain must be checked for obstruction, blockage, or kinking by flushing, and all this is going to be the trained nurse job. Ensure adequate analgesia. Once again, they are insisting in this guideline for the analgesia, so keep it in your mind, please, and encourage patient to move freely when well enough. We have a very crucial element in the pleural effusion management, which is a fibrinolytic agents, intrapleural fibrinolytics, indicated if thick fluid with loculations or pus. It's very crucial to use it in here. How you're going to use it, you will install urokinase according to the body weight in here. If it was 10 kilograms or more, 10 kilograms or less, anyway, you will check your local hospital guidelines and protocol where you work, or you can check the BNF where you work as well. You cannot memorize any doses in here. Administer via chest drain 12 hourly for 3 days. So you're going to install the urokinase every 12 hourly up to 3 days. You will clamp the chest drain for 4 hours after installation, and then you will leave it to drain for 8 hours, and that's in total 12 hours. Record fluid volumes into and out of pleural space carefully and accurately. Subsequent management, what you're going to do for follow-up or for complete management of this patient act on response to treatment and clinical assessment of patients. So the clinical assessment of the patient in here is very important. You will take it from there. You will monitor symptoms and re-examine the patient to assess progress. In the lab, you will repeat the CRP, C-reactive protein, as needed. If CRP is falling rapidly, you will continue in your current regime of antibiotic management. If CRP not falling after 72 hours of treatment, treat as non-resolution. We will check it down below. Chase pleural fluid aspirate results. If unexpected organisms growing, adjust antibiotic therapy with antibiotic sensitivity. If differential cell count shows lymphocytosis, you will discuss with the TB team as well. Send aspirate for a cytology and consider CT scan. So this is another indications of CT scan in here. I highlighted the indications of CT scan in red. The first one in here in the previous page was if you are suspecting malignancy, you will do CT scan. This is the first indication. The second indication in here, if you have found any differential cell count of the pleural effusion analysis, which is lymphocytosis or high lymphocyte count, you will request and discuss CT scan for the for this patient. You will chase the blood and sputum culture results. If no growth, you will continue empirical treatment until patient improve. You will remove the chest drain when drainage minimal and in agreement with the respiratory pediatrician. Again, you have to work as a teamwork. It's not your responsibility by yourself. Oppose skin with steri stripes rather than sutures. You will continue IV antibiotic at least until afebrile. Change to oral co-amoxiclav. If penicillin allergy, oral clindamycin. When clinical improvement obvious, complete minimum of 14 days antibiotic. Continue antibiotic until CRP less than 10. Encourage early mobilization and exercise. Okay. If there was a non-resolution pleural effusion, if no resolution of effusion after 3 days or further complications occur, you will consider CT scan. This is the third indication of CT scan, which is a non-improving pleural effusion apart from despite starting treatment for 3 days now. This is the third indication for CT scans. So if you are suspecting malignancy, if differential cell count showing lymphocytosis, and if there's no any improvement or any response to the treatment beyond 3 days, you will request a CT scan after discussion with your team. If no fluid draining, check for obstruction by flushing. If drain cannot be unblocked, remove and replace. If significant effusion remain, discuss referral for thoracotomy with respiratory pediatrician. Okay. Surgery. When are you going to think about the surgical intervention? Of course, you will discuss with the pediatric thoracic surgeon. If effusion hasn't resolved, you did everything you can do, and it's still there, and it's worsening, and it's not improving. So in these situations, you will think about involving the pediatric thoracic surgeon in this. The child is still septic as well. He is not well. Okay. And what about the discharge and follow-up? Arrange a review by a respiratory pediatrician. Initial appointment is going to be 6 weeks after discharge. Once he come for the follow-up appointment after discharge, 6 weeks time, you will request a chest x-ray on his arrival or her arrival. If symptoms persist or recur, early referral to respiratory pediatrician. Okay, guys, this is the guidelines Pleural Effusion. I wish you like it. I wish you enjoy this video. Um, and thank you for watching. Please do let me know if you have any requests for reading any different guidelines in the future. You want like your exams very soon. I want me to do videos for specific guidelines. I will be so happy to do that. Thank you for watching, and bye bye.